Thank you, Keela, and thank you, Simon, for your excellent presentation on the prevention of childhood injury. This is a very confronting scene for most people. For many, it will also be a scene that will create fear when a severely injured child arrives in their department or in their environment, at the roadside, for example, for pre-hospital practitioners. And that fear is in many aspects based around unfamiliarity. It is the fear of the unknown. Even though perhaps you are a practitioner with experience in adult medicine and the delivery of care to injured adults, the arrival of an injured child throws all of your knowledge to one side and becomes very confronting. In that setting, it can become chaotic, errors can arise, and in that madness and badness, the experience for the child, the parent, and the team that are gathered around with sincere want to deliver good care can be one of a negativity, a sadness. We are aware of the high risk of death for some severely injured children. We are aware that trauma is the #1 killer of children in many settings. And so we are worried about the prospect of severe injury leading to death or disability. But what is it that saves lives in this situation? It is not particularly clever or skillful individuals. In fact, it is a highly structured and systematic approach. It is a structured approach which calls upon strict priorities, which will be familiar to many of you. It is a systematic approach which enforces and imbibes strictly pediatric approaches to this injured patient. There may be similarities with the way that you approach an adult, or there may be important differences. And we're going to highlight some of those similarities and differences in today's talk. It is a team sport, and teams caring for injured children, as they are also caring for injured adults, should be prepared and practiced. And one of the elements they should be practiced in is procedural competency. And at the end, I'm hoping to be able to unpack and demystify some of the procedures that might save a child's life. It is really important that we understand that whilst trauma may be our core business, the injured child insists upon us that we may not be able to simply go about our business as usual, because every aspect of this care needs to be pediatric in the way in which it is delivered, the expertise that deliver it, the skill sets and the philosophies that underpin it, and the experience of the injured child, which sits at the center of this trauma care moment. So as we think about the prioritization of the structures and the systems with which we respond to a severely injured child, I want to run through the A, B, C, D, E, and then T standing for tests and tubes in the care of these children. I want to highlight ways in which children are perhaps different or maybe similar to adults to enable you to deliver better care to the severely injured child when you next care for them. So if we think about A being for airway, it is well understood that a child's airway is prone to obstruction. And sometimes we think about that because the airway is smaller and therefore, for example, more prone to the relative changes of edema. But I want to actually highlight something that is bigger about a child, and that is that they have a relatively bigger occiput on their head. And the consequence of that relatively bigger occiput is it tips the flat line, the supine child, it tips their neck into relative flexion. It takes away the neutral position of the spine, something which we are trying to achieve, a neutral position of the spine to care for the potential for cervical spine injury in this child. It also brings the airway into a kink and increasing the obstruction of that airway. So for both of those reasons, we want to be able to take away the impact of the occiput, take away the flexion that it imposes on the neck. And the way we achieve that is to elevate the thorax, a thoracic elevation device. Now, a thoracic elevation device does not need to be something complicated. In fact, as seen here, it is simply a towel folded several times. And that elevates the thorax of this child. And up until the age of 8, it is typical that the thorax of a child would need to be elevated to open their airway to maintain a neutral position of the spine. It's a very simple and effective way to start off this child's prioritized systematic care excellently. Going beyond that and thinking about other aspects of A, we think about the cervical spine and the spine along all its length. And there are many ways in which cervical spinal injury and spinal injury differ between children and adults. That relates to the anatomy of the spine in the child and the mechanisms with which children who do sustain a cervical spinal injury do so. And we'll highlight that they are often very high levels of injury compared with the levels at relatively lower levels of injury seen in adults. And in and around the assessment of this child, understanding, can they be formally assessed? Can that spine be cleared? We may need to arrive at a decision as to whether we're going to use a collar. And whilst we can't go soft on the potential for cervical spinal injury or other spinal injury, we should go soft on spinal collars. And what do I mean by that? I mean that in many trauma systems worldwide, the trauma system which I work in being one example, we have now gone well away from the use of hard, rigid collars towards soft collars. And examples of the appearance of a soft collar is given here. The emphasis is no longer on spine immobilization because there is a recognition that we were never really achieving spine immobilization. They were words we used, but it was never an outcome we particularly achieved. And not only that, but the attempts to achieve spine immobilization through using a hard collar was exposing children, particularly the youngest of children, to the potential for secondary injury in and around the spine, and secondary injuries such as pressure and venous injury or venous congestion. Now, all of this was a negative against the fact that we were failing to achieve the positive of spine immobilization. So our actions have changed towards using a soft collar, and our language has changed towards talking about spine restriction of spinal movement. And that is where we need to be focusing. And for those reasons, we strongly recommend, whether it's in the pre-hospital or hospital setting, in this undifferentiated, uncleared spine, that we use a soft collar. Of course, the experts in spinal trauma management, be that a neurosurgeon or an orthopedic surgeon, they may wish to recommend some of the semi-rigid collars, such as a Philadelphia or Aspen collar. That's a specialist recommendation. I'm not in any way contradicting that. I'm talking about the undifferentiated child whose spine is not yet to be cleared. In that child, we can use a soft collar for maximal benefit overall. Moving now down the prioritization from A to B, what is there around the chest that we could highlight in the child? Well, firstly, chest trauma in children who are severely injured is common and dangerous. It is a common cause of severe injury and is a common cause of death in those children. And when we look at the experience of our hospital and the children who have severe chest injuries that we receive, we find that about 2 in 3 have a lung bruising or lung contusion. Even though rib fractures are often thought to be uncommon because of the compliant nature of the child's bones, we see in that subgroup 1 in 3 have rib fractures and 1 in 4 have a pneumothorax of some kind. Thankfully, the more serious clinical scenarios of a significant hemothorax is less common, 1 in 10, and even less common again is the intervention demanding situation of a tension pneumothorax, 3 in 100. And the key question we need to be asking here is, does this child need life-saving pleural decompression, either around a suspected or known chest injury, or perhaps in the setting of traumatic cardiac arrest? And we're going to park that question. And later in the presentation, I'm looking forward to talking to you about some tips on pleural decompression and explain to you why I say it's a kind of magic. When we think about the circulatory assessment, it is often correctly highlighted that children can maintain a normal blood pressure, a blood pressure within the normal range, despite losing significant volumes of blood. And it's that compensation which helps to protect the child's physiology from the consequence of the injury that they've sustained, even in the setting of significant blood loss. Now, that blood pressure compensation is excellent. But if it is to fail because the body can no longer compensate, then that child with the low blood pressure, they are on a precipitous decline. They are in pericardiac arrest situation. So it is great when they compensate, but it is terrible when they can no longer compensate, because that reflects a child whose physiology is very embarrassed in the setting of typically in the setting of hypovolemic shock. But there can be some other contributors in the setting of severe trauma. So to make sense of a child's heart rate, of their blood pressure, we have to recognize that at different ages, a child's blood pressure or heart rate has different expected normal ranges. So we can't just take our business as usual adult idea and say, well, a blood pressure systolic less than 100 or less than 80 must be providing us with some information without first understanding where would we expect that child's heart rate, blood pressure to be relative to their age. It's important, just if we start to think about what we expect, also to know that in the setting of even significant truncal trauma, the majority of children who come to our hospital, many of whom will have had blood loss, actually have normal hemodynamic parameters. They are hemodynamically normal, despite the fact that they have had significant injury. So the normality of a blood pressure and a heart rate and the stability of the blood pressure and the heart rate are reassuring as to the current status of the child, but shouldn't discourage us from synthesizing or in considering particular injuries in and around their trunk or elsewhere in their body. When we think about how we're going to resuscitate children, if they are losing blood, we should be replacing blood with blood or blood products. There is a significant debate as to whether blood transfusion should be in the form of a balanced transfusion with red cells, platelets and plasma given separately in various ratios, or whether whole blood is the best. But what we've gone right away from, because we understand that it can cause injury in the setting of severe trauma, is crystalloid resuscitation. It was been very well put by Phil Spinella, who said that salt water is for cooking pasta and blood is for saving lives. So if this child is bleeding, let's give blood or blood products, and I'll leave it to you in your setting to know which is the better, a balanced transfusion or whole blood. Moving one step down the prioritization of this systematic, structured approach is the assessment of a child's conscious state. And because some of the aspects of the Glasgow Coma score can be hard to marry up against the age of this child, where perhaps incoherent speech is the norm. Perhaps the child is just so frightened they're not going to do as we ask. They might be withdrawing away from us as if they are showing poor GCS, but that might just be a response of fear. Because of all of this, we need to have an accurate way of assessing a child's conscious state. And we understand that the assessment of the conscious state is absolutely important for the child, because children who have these much larger heads relative to the size of their body and therefore sustain many injuries in and around the head, either as a consequence of its size or the ways in which the size of the head can impact with a mechanism of injury, such as a whiplash injury, which can be devastating in a child, or a child being shaken, or a child being struck on the head. All of these amount to significant threats to the life of the child. And it is a sad truth that head injury is the #1 killer of injured children. So, bringing all of that back, we have to assess the conscious state. A Glasgow Coma score is very important to the specialists, such as neurosurgeons, but can be quite challenging and doesn't necessarily impact the way in which people like myself, providing primary trauma care, look after this child. For all of those reasons, I and others recommend that we use the scale AVPU, A for alert, V for voice, P for pain, and U for unresponsive. And scoring a child on that 4-point scale is both informative as to the trend of their conscious state, and informative as to when their conscious state drops in a way that, were we measuring GCS, we would normally respond with an action. So, for example, the important GCS of 8, below which we perhaps might consider interactions such as safety of the airway, a child that has an AVPU score of either A for alert or V for voice is 100% positive predictive value of having a GCS above 8, according to reassuring research in this area. And I've highlighted the reference for you here, and you can see some of those results depicted. Right. What about the environment in which all this is happening in? Maybe you're at the roadside. Maybe you're in a hospital. Maybe it's a hospital that's used to receiving trauma. Maybe it's a hospital that's not used to receiving trauma. But wherever you are, is your department or your environment, is it ready for children, or is it actually upsetting for children? Is it rated R18+? Typical ways in which we can improve our environment, no matter where we are, is to improve the warmth. Yes, there's a discussion around hypothermia in trauma. Let's park that to one side and say it's not relevant specifically to this discussion. If the heaters in your environment aren't on, you need to turn them on. You need to turn them on as early as you can, because keeping this child warm will be important for their good recovery. It's a very busy environment. There are many roles that need to be filled to deliver a team approach to a structured, systematic delivery of trauma care. But that makes for a very busy place. So we need to ask ourselves, do we have everyone that we need? Do we have all the roles and the participants in this team that we require to deliver the care that this child needs? One of the forgotten members of that team are the parents. There is a great body of evidence that affirms that it is best practice to include the parents within the experience of this child's resuscitation. It is not for all moments, and it is not to be done without sensitivity and compassion. But please bring parents in and include them in and help them to understand the great care that their child is receiving from very committed clinicians. But in that busy environment, there may be people that you don't need. There may be people who perhaps are looking on but not contributing through a role. That is a crowd control that needs to be attended to. You need to ask those people respectfully to make way for those that do have something to provide. We think now about the tests that we do. Perhaps we should be asking ourselves, are our investigations R-rated, not just our department or our environment? And a really good way to think about this is our attitude towards CT scanning in trauma. The best evidence that I can bring to you, and I think the best way that we can think about the impact of CT radiation on children, comes from a study which was done within Australian young adults and published in the British Medical Journal in 2014. This longitudinal study identified that for every 1,400 CTs performed in young adults under the age of 20, for every 1,400 of those CTs, one of those young adults will develop a cancer in the next 10 years. And that risk increases incrementally by 16% for every additional CT scan performed. So it's really important that we understand that even though CT scanning has an important part in the assessment of the severely injured child, that it is qualitatively and quantitatively different from the part that it plays in the assessment of the severely injured adult. We strongly recommend that the idea of the pan scan be challenged in a child. By all means, you may make the active decision to scan each of the areas represented by a pan scan, but it should not be a simple decision to just get all of the scanning done at once because it makes it logistically easier or it somehow improves your assessments. It may not improve your assessments. It may prolong the child, deferring them from getting to the definitive care that they need, and it's exposing them to a level of radiation that could have significant consequences. And often clinicians, as I talk about this, they say, okay, well, who am I going to do a CT scan on? I want to flip that question around and I want to say, I think it is best to define who you're not going to do a CT scan on. And one of the reasons I flip it around in that way is because of the various tools and rules that I've come across that help me in my practice in pediatric trauma. The rules around not doing a CT abdomen and not doing a CT chest, which come out of large multi-centered North American trials, I think are the most useful. And I've given you the example here of a CT scan rule, which helps you to say no to an abdominal CT in the setting of severe injury. So if your child has none of the 7 features that are listed here, there is a negative predictive value of that child having a intra-abdominal injury requiring treatment that approaches 100%. These are negative predictive values and confidence intervals, which are just excellent and reflect the rigor of this project from which these data have been taken. And there's a similar CT guidance rule for CT chests in the same setting. And this is enabling us to safely say no to imaging a child. And we've looked in our own institution, and use of this tool would probably reduce safely, without missing injuries, our CT scanning rate by approximately 20%. Well, if CT radiation is an absolute no-no, and it should be done where it is required, but it should not be done where it can safely be avoided. What about ultrasound scanning? That avoids the radiation, it has greater traction. Unfortunately, ultrasound scanning, as it relates to fast scanning, has failed to stack up to the experience of adult trauma care. In children in particular, fast scanning lacks sensitivity, and this may be related back to what I said before about hemodynamic stability in this patient group. This is a patient group which does not usually present with hemodynamic compromise, and when fast scanning was delivered to adults who were injured who were not hemodynamically compromised, it also lacks sensitivity in that situation. But as many as 1 in 3 children who have a solid organ injury will not have free fluid on ultrasound. And there are a variety of reasons for that. It relates to clotted blood being echogenic, the obscuring of bowel gas, but there are many false negatives in the assessment of the child with a solid organ injury. There are also some false positives, because just because we find fluid in the belly does not mean there's an injury in the belly. And about 1 in 8 young children of both male and female genders, or male and female sexes, will have a physiological free fluid within their abdomen. And this is really important. It's also true that when we find some blood, if we say there is an injury and there is also fluid and it is actually blood and not just physiological, that does not in the child, because of the absolute success of non-operative management in those children for whom that is appropriate, who are the vast majority, the presence of blood does not mandate a next step. In many settings, it goes on to mandate a CT scan, which is perhaps one of the things we were going to be trying to avoid. But in that protocolized setting, it isn't even avoiding that potential negative. So one of the things I say about this is I think we should be going slow with fast in kids, but I'm looking forward to being able to turn that sentence right around and embrace fast when the ultrasound technology can provide us with a sensitive and specific answer. Well, I've just outlined to you some of the confusions that can arise, and another confusion that can arise in children is when they have changes, deteriorations in their vital signs and development of their abdominal signs. Often, not always, but in too many times, these deteriorations of vital signs and abdominal signs are actually due to distension of either the stomach or the bladder. Kids are very prone to gastric distension, to gastric dilatation in the setting of acute trauma, so we must decompress the stomach. You can see here examples of undecompressed stomachs. This places the child at risk of a vomit, and in the setting of a vomit in trauma, the risk of aspiration and iatrogenic injury. Not only do we have to anticipate this and respond by the passage of a gastric decompression tube, we need to check that it's being effective. The picture shown here on the far left of your screen is showing a grossly distended stomach with a nasogastric tube in place. That is a nasogastric tube which has been spigoted, and that is only being recognized secondarily, and that child will have benefited from having their stomach decompressed. I feel that the debate between nasogastric and orogastric has validity, but it shouldn't be a validity that distracts or delays that child having their stomach decompressed. In most situations, a safe decision can be made between nasogastric or orogastric, and the priority is to decompress the stomach. As it is to decompress the bladder, in the same way we can see deterioration in vital signs with changes in abdominal features, confusing as to whether we have a patient who has perhaps a deterioration in their abdominal status with maybe bleeding into the abdomen, or are we dealing with someone in urinary retention? The answer given at CT scanning is often that the child is in urinary retention. That child should have had their bladder decompressed already, and if not, you should decompress it now. Finally, let's think about chest drain insertion or thoracostomy in children to decompress their pleural cavities. In the setting of trauma, this is a very important procedure. It can be life-saving or life-preserving, but it is actually often, very, very often complicated by error and new injury. So we don't want that. These children are injured enough as it is. But let me ask you, how confident are you as to where you're going to perform a thoracostomy and a chest drain insertion, and how are you going to do that rapidly and safely to protect this child from ongoing injury? Well, I think that we can make pleural decompression easier in children for us as practitioners. And I want to just spend the last few minutes unpacking two tricks or tips that we've been able to establish in recent times to help you with this. Let's just be clear about what the problem is here. The problem is that we have air and blood outside the lung, inside the chest cavity. It's creating pressure. That pressure is dangerous, and we need to release it. So our number one priority is a thoracostomy to form a hole which lets that air and blood out, and that is going to save the life of this child. The number two priority is to put a chest drain in to keep that life, to keep that blood, that pressure from re-establishing. But the first priority is to form that thoracostomy, and we're going to hold those priorities through the discussion that follows. Now, we don't just in reality have blood, air, blood, sweat. We also have air, blood, sweat, and tears and fears, because actually when we look at this child, it is often completely confusing as to what we're going to do. Where are we going to cut? What are those anatomical boundaries of the safe triangle? You can't quite work out where you're going to be. You don't know what tube you're going to use. People start handing you things. They say, is this what you want? You think, I don't know. Let's dive into that moment of need and give you one magic number that you're going to use. Because without the magic number for chest drain, for thoracostomy and chest drain insertion, you're probably going to end up in the wrong hole using the wrong tube, and you're probably going to put your tube in too far. And that magic number, getting it right first time and getting it done quickly, is the magic number 4. And I want to tell you about the rule of 4s, which we teach here at the Royal Children's Hospital, and is becoming popular well beyond Australia into other parts of the world. So the first part of the rule of 4s is we're going to use 4-step plans, and we're going to use those 4-step plans to first form a good hole, which we're going to put in the 4th intercostal space. Why not the 5th? Because some people talk about the 5th. We're going to say 4th because you have one number to remember, the magic number, which is the number 4. So we're going to use our 4-step plans to first make a good hole in the 4th intercostal space, and we're going to use that hole and put through it a good tube. Now, many of you are involved in critical care delivery, and you'll be aware of the way in which we size an uncuffed ETT tube in children. And if you take that sizing, the formula for which is age over 4 plus 4, that'll be a familiar formula for many of you. If we take that 4-based formula and times it by 4, that is going to give us the good tube size that you're going to use in your injured child. So again, magic number, number 4. And we're going to do all of that, and we're going to insert the tube. And rather than just pushing it in as far as we can, which can lead to complication and reduce the effectiveness of a drain through kinking, we're going to start pushing it in, and then we're going to make our 4th part, which is our good stop. Where are we going to make that good stop? At the 4 centimeter mark on the tube. The 4 centimeter mark is not 4 centimeters from the tip of the drain. It is 4 centimeters from the last side hole, shown here in the various pictures. So it'll be a variable distance in according to the tube that you've used, but it'll always be a safe distance in our experience. So that's the magic rule of 4s. That is the magic number for thoracostomy and chest drain insertion. And you can see here various QR codes, which will lead you to papers and videos about how we do that. So 4 is the magic number. What is the magic trick for thoracostomy and chest drain insertions? And the magic trick relates to the mid-arm point. And this is something that other colleagues within Melbourne identified and popularized in adult trauma. It uses a point which is halfway between the olecranon and the acromion along the arm which is held by the side to begin with. And we then use that mid-arm point to mark the corresponding level on the chest. And we raise the arm into abduction, and we have that abducted arm there, exposing the area of the chest and saying, right, this is where we make our mark. Wherever the mark on the skin is, that's where we make our entry. And when these colleagues from Melbourne looked at this in adults, they found that in 120 adults in whom they performed this technique, it showed a safe zone which bridges the 4th to 6th intercostal spaces. Okay, we've talked about the 4th being optimal, but this is a zone of safety, the 4th to 6th intercostal spaces. in 100% of those adults. And we asked ourselves, what about in children? Now, in children, we wanted to be able to perform this, and we did this through a prospective study. We used 4 sites, both within Australia and Ireland, and we looked at children between 0 and 18 years of age. We used the chest X-ray that the child was going to get anyway. These were uninjured children we recruited into this study, and we also created a video that you're seeing in the side here to help people understand the technique by which the mid-arm point is used. And you can see here we've gone to the mid-arm point, and we're now going to swing it round and place the mark, not on the arm, but corresponding to the level of the mid-arm point on the chest. And in a moment, when I raise this child's arm away from their chest into abduction, you will see that the mark will go up ever so slightly, and then we'll be ready to put the chest drain in if this were an injured child, but it isn't. We did this in almost 400 children, and we found that 8 out of 10 times this identified a place within the safe zone. So it didn't perform as accurately as in the adult series. But when we looked at the data, we found that as in older children, there was a tendency for the mark created by the mid-arm point to be a bit too caudal, a bit too low. And we considered if there was, in fact, some growth changes which were playing a part here. The arm in a child grows in a linear fashion, whereas the chest in a child grows in a curvilinear fashion, in more of a logarithmic fashion. And for these reasons, we considered the fact that in older children, it might be necessary to go up 1 intercostal space. So we redid our analysis as if we were going to go up 1 intercostal space. And we looked at what would be the ultimate cutoff. And very excitingly, we found the ultimate cutoff, optimal cutoff shown by statistical analysis, was 4 years of age. So for a child 4 years or more, up until the adult age of 18, we recommend that you go up 1 intercostal space and into the space above the mark. And when we adjusted in this way, we now found that 9 out of 10 times the mid-arm point was providing entry into a safe, into the safe zone, the 4th to 6th intercostal spaces. And we published this experience, and you can see here the reference and the QR code. We termed this adjustment according to age the MAPED rule, and you can see it shown there that in a child under the age of 4, the mid-arm point alone will get you to the safe zone. But in 4 or more years of age, go to the mid-arm point and go up 1 intercostal space, and that will bring you into the safe zone. Now, I hope that one day you're going to be doing a thoracostomy or chest drain insertion on an injured child, and both the magic number 4 and the mid-arm point in children will assist you deliver that child safe and rapid care the way that they need so. Remember, the mid-arm point was only accurate in 9 out of 10, showing on target. So it's not foolproof. You do have to have your brain in gear as well. So thanks for your time, and I hope that you've enjoyed a bit of a run through pediatric primary trauma care. It's a lot to cover, but I hope that in that time you've been able to see things that will help you care for children who are injured. If you would like to reach out to me, I'm available on email, and the details for which are provided in the slides which accompany this presentation. Thank you for your time.